Good evening, everybody. And I see people beginning to join this evening's webinar. And I'm very pleased to introduce our speaker for this evening, Dr. Giorgia Michelini. And Dr. Michelini's talk will explore beyond diagnostic labels, a new approach to neurodiversity and mental health. So Georgia is an associate professor in neurodiversity and mental health at Queen Mary University of London. Since her PhD in developmental psychopathology and neuroscience at King's College London, she has been researching the co-occurrence between neurodevelopmental and mental health conditions across development. Her current research seeks to understand why neurodivergent young people are at higher risk of experiencing mental health problems and how to best detect, predict, and support co-occurring problems in this population. Her work integrates approaches from developmental psychopathology, etiological research, for example, genetics, transdiagnostic frameworks, and cognitive or affective neuroscience, particularly EEGs. She also uses participatory approaches and actively collaborates with people with lived experience and charity organizations to co-produce research projects and increase the impact of her work. So, as ever, we're joined by Ken Kilbride and Valerie Andrews as well this evening. Uh, so, looking forward to this talk from Georgia. And of course, as ever, please do not hesitate to pop your questions or comments into the Q&A box. Over to you, Georgia.
Thank you so much, Tammy, for the introduction and to the whole committee for inviting me. It's a real honor to get to share some of our work with you all. So we'll go ahead, share my slides so we can get started. Hopefully you can all see it. Yeah, all good. Perfect. All right, thank you so much. I've slightly tweaked the title since sending, but the overall message is similar. So the work that I'll be presenting is going to reflect on some of our work and other researchers in the field, particularly thinking about neurodiversity affirming approaches to guide mental health care. This is a quick outline. I'll start thinking a little bit about the challenges that we see in clinical settings and how the neurodiversity paradigm is now emerging as a potential way to help us address some of these challenges. And later, I will then present two approaches that I think are particularly promising for aligning our research with neurodiversity affirming practices, and then hopefully move us closer to better care, better support for the neurodivergent community. This is obviously not new to anyone, but just to get us all on the same page, I will be focusing on neurodevelopmental conditions as an umbrella term and very much lining up the concept of neurodivergence with the broad range of neurodevelopmental conditions that we see in traditional diagnostic manuals. And these manuals we know have been useful in many ways. They provide clinicians with useful guidelines and a common language, but they've also held us back in many ways. We know that there are significant challenges in establishing boundaries between individual diagnoses. There is a lot of overlap between different conditions in terms of presentations, and these manuals really don't account for the very wide heterogeneity we know exists within individual conditions and in the whole spectrum of neurodevelopmental conditions. And they've also been an active barrier in some instances to actually identifying co-occurring conditions, a phenomenon that we know as diagnostic overshadowing, when having one diagnostic label means that it becomes more difficult for somebody to then also receive support for a co-occurring condition. One is a particular example of this is when we see that the mental health needs of children and adults who identify as neurodivergent, who have a neurodevelopmental diagnosis, uh, struggle to access support for any co-occurring mental health conditions they might be presenting with. However, we know that co-occurrent mental health challenges are really the rule rather than the exception. There are broad estimates that vary across studies, but we can think of about 2/3 or one or 3 in 4 neurodivergent individuals as being affected by additional mental health challenges, particularly when thinking about depression and anxiety here. We know that these are particularly significant, but there is also emerging interest in other conditions such as eating disorders. These sometimes present as fully met diagnostic criteria for additional conditions, but in any other instances, we also often see subthreshold presentations where somebody will have certain levels of anxiety and depression that maybe will fluctuate and change over the course of development, but that can be very much impairing. That's what I was saying earlier. One aspect that makes co-occurring mental health challenging particularly concerning is that it can be an important risk factor for very severe outcomes. This is something that we see quite robustly across evidence from both epidemiological studies and clinical studies, but that in more recent years have also been highlighted very strongly by lived experience accounts and more research done using qualitative and participatory approaches. And I will get back to this a little bit towards the end of my talk. Given the challenges that we see in providing better identification for current mental health challenges within the context of neurodivergence, several organizations worldwide have really been calling for more attention to these issues and really improving early identification and better evidence-based practices around mental health challenges in neurodivergent people. With the Embracing Complexity Coalition in particular, really pushing for a new approach and new frameworks for understanding this co-occurrence using neurodiversity affirming practices. And I had the pleasure to be an active member of a special interest group that was chaired by Embracing Complexity a few years ago. I obviously don't need to tell anyone here what neurodiversity is and what the neurodiversity paradigm is doing. But one point that I would like to emphasize that really has, I think, really been really powerful in the neurodiversity movement and the establishment of the neurodiversity paradigm is that it has really pushed researchers investigating neurodevelopmental conditions to really start shifting their priorities on what the research priorities of the neurodivergent community are. And mental health has, in recent years, really ranked among the top priorities of this community internationally. So it's something that a lot of people have started paying more attention to in the last 5 to 10 years. There are a couple of approaches in research that I think are particularly well aligned to the neurodiversity paradigm, and that can be especially useful when wanting to better understand the co-occurrence of mental health and neurodevelopmental conditions. I will spend most of my talk going over some of the work that we have been doing in the transdiagnostic space using transdiagnostic approaches, but participatory approaches are as valuable as transdiagnostic ones, and we have been starting to do some more work in this area. So I will finish off with highlighting some of these more recent projects. So what is the transdiagnostic approach? A transdiagnostic approach essentially is one that helps us conceptualize psychiatric conditions not as traditional categories, diagnostic categories like we see in the ICD or the DSM, but rather pushes us to think dimensionally and conceptualize psychiatric condition, traits, and symptoms in a more dimensional way. This approach is very useful for allowing us to understand what might be processes or dimensions that cut across diagnostic boundaries. And that may be common across different conditions, but at the same time, it allows us to get more granularity in being able to understand what might be specific aspects of needs or dimensions, subdimensions of functioning or of traits and clinical features in a more detailed level. One application of transdiagnostic approaches that is particularly fruitful, I think, to the neurodevelopmental neurodiversity space is the ability to understand how various conditions can co-occur with each other and share similar presentations. So if we think of classic transdiagnostic approaches, these will include dimensions such as the internalizing spectrum, externalizing spectrum, or psychosis spectrum. And you see that these can be used to then encompass or sort of help us cluster individual conditions or individual subdimensions that tend to hang together in data or tend to very often co-occur within the same person. So one example within the if you look at the externalizing spectrum, for example, we see that alcohol use often co-occurs with drug use and often co-occur with antisocial behavior. And then in the internalizing side of things, fears, anxiety, depression often hang together and can be understood as being encompassed or subsumed by this internalizing dimension. However, these transdiagnostic frameworks, despite being very well established or starting to be well established in clinical psychology, particularly concerning the conditions that I was just discussing, has lagged behind in being able to integrate neurodevelopmental features and aspects of neurodiversity. These frameworks tend to consider ADHD to some extent, but have really neglected several neurodevelopmental conditions and aspects of neurodivergence, such as autism, learning difficulties, and the whole spectrum. This is primarily because a lot of the work in that space has been conducted on adult samples, and traditionally our sort of studies that are large enough have not collected these more childhood onset, or at least often thought to be more childhood onset conditions into adulthood. And this has been a real barrier. So what happens really is that if we look at some of these transdiagnostic frameworks, they actually don't have any of the conditions that we consider to be neurodevelopmental within them. An example is this framework that some of you might be familiar with. It's called the hierarchical taxonomy of psychopathology. This is used quite a bit in clinical practice in the States in particular, as a possible alternative to DSM-based type of clinical practices. And this is all very small, so the point is not for you to look into that in detail, but if you think about, you can sort of like see how this sort of like approach organizes various clinical features with general broad dimensions at the top, and then these get sort of like more and more detailed over a hierarchical structure with more detailed subdimensions included within each other. But what I want to highlight here is really that although ADHD, some aspects of ADHD are somewhat represented within these models, you really don't have any representations of any other neurodevelopmental conditions and related traits. in parallel with this large transdiagnostic literature, there has also been more and more interest within the neurodevelopmental space on clustering among neurodevelopmental conditions. So many of you will be familiar with the paper by Duncan Russell and colleagues and other contributions. What I will be focusing on here in particular is this piece that we published a couple of years ago now, where we have essentially tried to bridge this emerging transdiagnostic interest within the neurodevelopmental field with the more established tradition of using transdiagnostic framework in psychiatry and clinical psychology. So what we essentially proposed within that paper was that it will be possible to include neurodevelopmental conditions and related features within these broad transdiagnostic frameworks by considering what we called a neurodevelopmental spectrum, which we defined as the broad dimensions reflecting the shared features and underpinnings of various neurodevelopmental conditions. And we argued that integrating this dimension, this neurodevelopmental spectrum, alongside other well-established dimensions that are already included in transdiagnostic frameworks in clinical psychology and psychiatry, would allow us to gain a better joint understanding of neurodevelopmental conditions and co-occurring mental health conditions, which would lead not only to better understanding, but also better identification of how this condition might be co-occurring over the course of someone's lifespan, and importantly, better support for mental health conditions in neurodivergent people. So the model that we propose essentially looks like this. These are the sort of traditional dimensions that are included within transdiagnostic frameworks. And as I was saying, a lot of this work has been done in adulthood primarily. What we suggest is that we really need to integrate this neurodevelopmental dimension to then be able to fully understand what might be the challenges that people present in relation to their neurodivergence, and then co-occurring or later emerging presentations of other mental health conditions throughout the life course. With the neurodevelopmental spectrum here, essentially capturing and encompassing all traits of neurodevelopmental conditions. This model was based on quite extensive literature review, and so when we look at the data, it's useful to think about how actually what kind of data actually is supporting this neurodevelopmental spectrum that we put forward as a way of understanding co-occurrence with mental health conditions. Quite a large literature, as I was saying, has established a coherence and psychometric evidence for these broad dimensions that exist in transdiagnostic frameworks. And when we also include within these studies traits that are characterizing neurodevelopmental conditions, ADHD, autistic traits, learning difficulties, communication, and so on. And we run statistical technique that essentially allow us to look at how all of these features hang together and co-occur. We are then able to delineate this additional dimension. So this essentially means that you can identify this dimension or spectrum of neurodevelopmental traits that captures the covariation of all neurodevelopmental conditions or related neurodevelopmental traits. And this would separate from dimensions that instead capture traits and symptoms of internalizing, externalizing, and psychosis. One example of such work is a study that we published a few years ago now. It was conducted in a very large sample of children in the US. And what essentially we see is that we can delineate a neurodevelopmental spectrum And this is capturing items from that were derived from a very large battery of questions asked to that the parents completed. And among all the various questions, there were questions of ADHD, cognitive disengagement, autistic traits, motor difficulties and learning. All of these questions hang together and were clustered within this neurodevelopmental dimension, whereas traits and symptoms of anxiety and depression hang together in an internalizing dimension, for example, and behavioral challenges, problems with conduct or positionality, for example, separated in an externalizing dimension, just to pick up a couple of common co-occurring conditions. This study was one of many studies that are supportive of this idea of a neurodevelopmental dimension using similar methodologies. And here is just like a table to just give you an idea of the extent of the literature here that you can look into more detail in the paper that we published. We then ran a more recent study using a very large study of children in the UK to address some of the limitations of the previous literature. These limitations were that lots of these studies have been cross-sectional in nature. Our previous study was, and most of these in this table are, and they also had a relatively limited coverage of traits of neurodevelopmental conditions within them. So we need to do, and we continue to have to stand in this direction, really, of doing studies that have a better coverage of all neurodevelopmental traits and features within their assessments, in addition to clinical assessments of mental health conditions, behavioral challenges, to really be able to look at the co-occurrence. The sample that we use here is an example of an excellent resource that has collected all of this data and has done so over a number of years. So it's a longitudinal study that followed up children from their birth now into their 30s. And within this study, we were able to get very good assessments of a number of neurodevelopmental features, together with internalizing, externalizing features over years when participants were 7, 12, and 16, with additional more like adolescent onset conditions also included within the adolescent time point. A study here, the analysis included between 10 and 15,000 participants over time. The structure that we find very much resembles some of the previous studies that we have done. Here we find a similar neurodevelopmental dimension or neurodevelopmental factor that, similar to previous studies, included items and traits that broadly capture neurodevelopmental conditions. And in particular here, we saw very strong representation of inattentive features of ADHD, learning difficulties, and some representation of autistic features, although it's worth noting that in this age 7 data at least, a lot of social features of autism actually hang together better with or internalizing traits within this model. At the second time point, at age 12, we similarly identified this factor, again, capturing a mix of ADHD and autistic feature, and the story was similar also when we looked at age 16, where again, we had good representation of traits of ADHD and autism. It's worth noting here that at this last two time point, age 16 and age 12, we actually didn't have additional traits beside ADHD and autism within this assessment. So that's why you don't see the learning difficulties at this wave and the previous one that we instead see at age 7, where we also see these traits hang together in the neurodevelopmental factor. What we then wanted to ask, and we have done in this study, another study, has essentially been to figure out whether considering this neurodevelopmental dimension is actually any good for anything. Is it useful to consider this dimension from more practical sense? Does it explain outcomes that are important? Does it explain functioning and mental health conditions in particular, given our interest? And so what we have done has been first evaluate the literature on utility of neurodevelopmental dimensions, and you can read more about this in this review paper. But we've also looked at this in the same sample, the TED sample that I've just presented, where we looked at how the age 7, 12, and 16 neurodevelopmental dimension predicted a wide range of outcomes, particularly focusing here on learning difficulties and cognitive challenges. And what we see is that this neurodevelopmental factor predicts both concurrently at the same time and also future cognitive challenges and educational challenges. So we see that up to 21% of the variance in some of these educational academic outcomes was explained by just this neurodevelopmental spectrum over and above any covariates that we often see associated. So it's a meaningful amount of variance that we can explain here, suggesting that if we investigate and sort of like are able to map out neurodevelopmental challenges or traits captured by this neurodevelopmental dimension, this could then be useful to forecast any challenges in educational settings or any needs that a child might have down the line. The second piece of data that is relevant to understanding the utility of this neurodevelopmental dimension is this other study where we went back to our data in the ABCD study, the factors that we had identified when participants were age 10, and in particular, whether the neurodevelopmental dimension at age 10 predicted later mental health conditions captured by these other dimensions of internalizing, externalizing traits, and so on. And when we do this, we find that the neurodevelopmental spectrum predicts these later mental health outcomes over and above baseline levels of these outcomes. So we find, for example, that the neurodevelopmental factor at age 10 predicts internalizing, externalizing 1 year or 2 years later, even controlling for their age 10 internalizing, externalizing score. So it does pick up this unique variance that allows us to predict future behavioral and mental health challenges. And then we asked what might be some factors in the environment or in these children's lifestyle that could be contributing to the emergence of mental health challenges in children with elevated neurodevelopmental scores. We looked at a number of possible factors that are relevant in the literature, related to parenting, conflict within the family, neighborhood safety, and so on, in addition to lifestyle factor. And the thing that did come out as the most consistent across the outcomes and across time points, even when we use very stringent analysis controlling for other factors within these models, is a strong role of sleep. So what we see here is that neurodivergent children or children with high neurodevelopmental traits in this sample were then more likely to experience problems with their sleeps. And this, in turn, 2 years later, led them to be more likely to experience mental health challenges or behavioral challenges. To summarize this part before I continue briefly with the participatory aspect, these data are suggesting to us that we can use this neurodevelopmental dimension to help us understand how neurodevelopmental traits cluster together, and in a way that, at least to me, provides strong evidence for the notion of neurodivergence as being an umbrella term for all of these conditions. But in my mind, it sort of like corroborates and provides nice sort of data to really speak to how this, what we know from lived experience is really true and really reflected in the data besides what people with lived experience report. We think that this transdiagnostic approach can be useful for identifying this broad range of needs and traits related to neurodiversity, but also predict functional outcome and mental health outcomes, even in a longitudinal way. So potentially helping us forecast or even prevent later at some point some of these challenges. And then finally, hopefully, this could really then also support the development of more tailored preventative approaches to improve mental health outcomes in this population. What our most recent work that identifies sleep as a key target suggests is that transdiagnostic interventions that target sleep difficulties in neurodivergent young people could then have a very positive impact in preventing a broad range of mental health and behavioral challenges over the course of transition between childhood and adolescence, at least in this data. I will briefly touch on participatory approaches. This is an area where we haven't done quite as much work thus far, but where we are growing and hoping to sort of bridge this more transagnostic tradition with participatory involvement as well. There's a very impactful work in this area that many of you will be familiar with. The work of the Restart team is something that I always cite as a clear example of really forward-thinking way of including the neurodivergent community and co-producing work with them, in particular in relation to co-occurring depression and mental health challenges. And we have started doing more conceptual work, at least, in trying to integrate participatory approaches with transdiagnostic approaches. This is a viewpoint led by a brilliant autistic PhD student at the University of Minnesota, where we essentially lay out some of our thinking around transdiagnostic approaches that span both neurodiversity and mental health as useful ways to improving recognition for mental health conditions in neurodivergent people. And then finally, I will finish with a couple of examples from research work that we have done using participatory approaches that involved the involvement of panels of neurodivergent people, young people in particular, young adults, to really understand what are their priorities around mental health research in the context of neurodiversity. This is something that has really shaped our research since. And this first project was led by a PhD student, Shitilu, in my lab, that produced this beautiful infographic with the people with lived experience panel, also in collaboration with the McPin Foundation. And if you want to read a summary of this project, you can scan the QR code here. I'm also happy to circulate the slides or links later if useful. And building on that previous work, one aspect that has really kept coming in our discussions with this neurodivergent young people panel is that one key aspect of improving research on mental health conditions, improving care for mental health and neurodivergent young people, is that we really need to get a better understanding of how mental health problems or challenges are expressed, present, and are experienced in neurodivergent people, with the idea that most of the assessments that are used in clinical practices might actually not pick up some of the mental health challenges that neurodivergent people experience. There might be neurodivergent specific mental health challenges that are not very well reflected in these assessments because these have been developed mostly with neurotypical typical people in mind, and not really trying to understand how well they are also mirror representations and experiences in people with a preceding history of neurodivergence or neurodevelopmental diagnosis. This is work that is led by my PhD student, Hama Amashibara, also neurodivergent. So it's really a wonderful co-produced project that we are doing with another panel of neurodivergent people and in collaboration with charities. Autistica is collaborating on this work. So to summarize a little bit, I hope that in this half an hour or so, I have been able to share with you why I find transdiagnostic approaches to be really quite promising way of better understanding the co-occurrence between neurodevelopmental conditions and mental health challenges, particularly as a way of doing neurodiversity affirming research that can really get a better and more holistic picture at what the various challenges and strengths and needs of one individual might be, and then understand how different challenges or strengths might relate even over the course of someone's development. Hopefully, these approaches will then allow us to develop better, more holistic, broader types of assessments of a wide range of strengths, needs, and challenges. We know that a lot of the clinical services, certainly at least in the UK, are very narrowly focused on just assessing for the one condition that person was referred for. So they'll get assessments for autism. If they're lucky, they'll also get a little bit of assessments for maybe ADHD, but nothing else, or very rarely a very comprehensive mapping of other co-occurrence difficulties is done. But we really think that this would be really important, and hopefully transdiagnostic approaches like those that I presented here will improve better identification and then better access to care for a wider range of challenges and needs. My hope is that pushing this more like broader assessment, more and more holistic way of looking at things, we might then be able to catch some emerging presentations of challenges in the context of neurodivergence. So we don't wait for that anxiety, that depression to really reach tipping point and have like a neurodivergent young person find themselves in A&E to then recognize that there is a mental health needs that need to be addressed. Hopefully we'll catch some of these problems earlier, and this will hopefully have not only a tremendous impact of that person, that family, that community, but also maybe reduce waiting lists that we see in clinical services and long-term costs. In the future steps of our work, we are really trying to incorporate participatory practices throughout everything that we do. We are now also working on creating more of these transdiagnostic assessments, spanning neurodevelopmental traits and co-occurring challenges. Hopefully, again, providing more holistic assessments of individuals' needs and traits and challenges. And then in future, to really move this into clinical care, it will be really important to do more implementation work in this area and see what's the impact of these type of approaches when we embed them in clinical care. So that's all for me. I hope that it wasn't too much. It was a bit of a whirlwind of the work that we're doing, but I hope you found it interesting. So huge thank you to my lab members and great collaborators worldwide that make this possible, collaboration with charities and the neurodivergent community in the various panels that we have organized over the years, as well as all our funders. If you also know of other funders that could be interested in this type of work or organizations or philanthropies, please link us up because there's always more need for funding for this type of work. Thank you so much for your attention.
And thank you very much, Georgia, for your presentation this evening. And
I might stop
it's,
sharing unless people
oh,
want to.
sure, sure, good
Yeah,
thinking.
I can pull sides up if helpful.
Great, great. So, I know Valerie and Ken may have some questions. I know I've one or two, but of course, for the people viewing this evening, if you've any questions you'd like to ask, please do pop them into the Q&A. And just to answer, Natalia has asked if this presentation will be available. It's usually up on our website a few days after the presentation, so you can have that to look forward to. And Georgia, just to check with you, I was really interested in the concept of sleep and how sleep was a predictor of potential future outcome or the co-occurrence of a mental health uh, uh, illness. And I'm just wondering if you could comment a little bit more on sleep, because I'm sure it's a very relevant topic for many people.
Yeah, so that's, you know, we were really interested in seeing sleep come out so strong and so consistently because that's something that is not often addressed in clinical care. Neurodivergent people, you know, poor sleep is for many people is their normal. And yet, since sleep is not very diagnostic specific, it's something that, happens to many people. It's very rarely addressed clinically as a core aspect, although for many people it's really one of their key concerns. So seeing this, essentially what we find is that sleep is a longitudinal mediator. This means that even when we control for earlier sleep challenges, and earlier mental health problems, then we see that on top of these, neurodevelopmental traits will predict poor sleep later on, and in turn, poor sleep will predict later mental health challenges across a very broad range. We expected something to be a little bit more specific to anxiety, depression, but really it also predicted later behavioral challenges, which I think really makes sense because for anyone who's had a bad night of sleep or struggles with sleep, we know how pervasive the effects of bad sleep can be on someone's behavior, someone's mental health, someone's physical health. So it's really something that we hope to be investigating more in the future. And I think definitely for people working on intervention, something that can really be a really important target to prevent negative mental health outcomes.
Hmm. And a final question for now from myself. What would be the next steps in your research? What type of projects would help to advance your work from a research perspective?
Yeah, that's another great question. So we are doing a few parallel things. So we are definitely building more on this work, this qualitative work and participatory work that we're doing in understanding the lived experience of mental health challenges in neurodivergent young people. From this early work led by my PhD students, we really see how people comment on how some questionnaires for depression, for example, really don't work for them. They're not picking up on their experience. They don't see themselves seen in these, questions that are asked in these assessments that are used very broadly, very widely in clinical care. So the next step for us will then be to use this information and really generate better content for these types of assessments and then develop assessments with neurodivergent people. We are going to do this summer more co-production workshops to start developing and designing these assessments for mental health challenges that would be tailored and specific to the experience of neurodivergent people. So that's something we're really looking forward to. And then the other thing that we are just working on, and we just put a preprint out, is actually also thinking about, if we want to predict these, future depression in adolescents, for example. A lot of these studies have focused on risk factors and developed these fancy machine learning prediction tools but very often taking a more general population approach rather than thinking of the people who might be at higher risk. So in a study where we have looked at developing a prediction algorithm for later depression, we've done this in a general population group. We've then tried to see whether it predicts later depression in individuals with an ADHD diagnosis just as well as it does in the general population. And we see that it doesn't. So the prediction drops dramatically when you
Hmm.
try to apply these sort of algorithms that are being developed in the, in the general community to those that are actually at highest risk and that we would want to prioritize for this sort of prediction and prevention effort. So we're definitely
Hmm.
hoping to expand in that area to, push for, again, like a similar thread here is more personalized, more tailored mental health approaches that really hone in on the challenges of neurodivergent people and the presentation of mental health challenges in neurodivergent people, which are different, and we just need to recognize that better.
Hmm. Yes, it sounds like, what you've just said there in the last moment or two would be very important for clinicians to be aware of in terms of the specificity and the sensitivity of any assessment tools that might be in use. Uh, but not to hog the limelight, Georgia, I will just check in with others. If there's any questions from people watching this evening, or indeed Valerie, Ken, if there's anything you'd like to add.
Well, good evening, everybody. Thanks a lot, Georgia, for your presentation. It was very informative. Um, just a couple of questions, just for myself, just teasing into it. At the very start, you would have listed, conditions under the neurodiversity umbrella or paradigm. And again, within that, you had autism, dyslexia, but you've had other conditions like ID. Um, you could make a suggestion that, conditions like autism, ADHD are primarily genetic in their etiology, where ID wouldn't be. Is that a useful way of looking at things, or we just, it's simpler just to use the entire or conclude everybody under a neurodiversity umbrella?
I think that that's a really good question, and that, like thinking about what might be common across this condition is as useful as understanding what are the differences, both in terms of etiology and the clinical presentations. In my mind, a lot of the work that has been done, historically in research has always been, taking one disorder, looking at things and not really considering other co-occurring presentations that really create so much variability in that sample that you put together. When you then take a more transdiagnostic approach, I think you start very broad, but this then also allows you to zoom in on certain aspects and understand how sub dimensions within a broad neurodevelopmental dimension or spectrum could then be showing more specific associations or stronger associations. So we might find that there is a broad association between the neurodevelopmental spectrum and sleep, but then we can also zoom in and look at what are the features of autism within this neurodevelopmental spectrum. I compare them to the associations of features of intellectual disability, ADHD, and see whether maybe we find any meaningful differences in the way they associate with these outcomes. But if we don't start broad, we're then not able to go and look at
No.
these granular dimensions.
You just mentioned there autism, and obviously, just one of the challenges, and we're seeing this an awful lot more in ADHD Ireland, and I dare say they're seeing it across the UK as well, is that the very high levels of now presentation of the orders ADHDers, and so you're seeing the person will be presenting with both ADHD and autism.
Mhm.
Um, over the previous years that has been causing challenges for clinicians in terms of making the diagnosis. Do you see your approach being able to help people in terms of the clinicians in terms of making assessments for people that would be ADHD and or autism at the same time?
Yes, no, I mean, I do hope that it would be a possible way to move the discussion forward. I mean, in the UK, we have, all this attention to diagnostic rates, overdiagnosis, misdiagnosis, underdiagnosis. One thing I really hope will come out of this discussion is that the diagnosis in itself needs to be used as a diagnosis. It over time has sort of like taken different forms that have moved away from what diagnoses were originally designed for. And we've also seen that diagnoses in themselves have not been always very useful for understanding the individual needs that somebody have. Two people with the same diagnosis can have a very wide variety of challenges and needs and strengths that don't overlap. And then when you think about even broader co-current diagnosis, so autism and ADHD together, that even expands the number of possibilities. But instead, if we don't think of the actual diagnosis that somebody has and we look what's underneath these, what are the, the dimensions of functioning, dimensions of traits and features that characterize that person, I think that we will be able to, like have a better understanding of, like maybe that person has a certain set of autistic features that are associated with certain areas of functioning, but they also might present with co-occurring challenges that relate maybe a little bit more to ADHD, some other ones that relate a little bit more to learning difficulties, but we don't get too hung up on what's the actual diagnosis that these are. That we also know that there is some overlap between them. So maybe it's not that useful to think of that diagnosis, but rather really go underneath it and look at how the needs and features really are associated with functioning and various aspects of someone's behavior and needs.
Just a couple quick questions just for myself. Just to delve a little bit more into that point you were just making there. You could make it nothing the opposite of point, in that you could argue that both autism, ADHD, conditions like that are not mental health conditions per se. It's
Mhm.
only when society doesn't treat them properly that they become mental health conditions. And therefore, if you look more towards the social model,
Yeah.
and move it away from a trans diagnostic perspective, you may end up in a better position. But
Yeah, no, and
that's just a question.
that's something that is, incredibly important as well. I mean, if these diagnoses were, they originated in the medical,
Mm.
under medical model. So that's why I think it becomes challenges to then sort of like ascribe to them more functions that they were designed for, and expect, that we can, they can sometimes be, you know,
Okay.
also, yeah, I don't know, but
No, no
I
problem.
completely agree. We needed to also consider the social models.
Mm.
What I would hope is that we can really move to away from having so much attention to these diagnostic rates, having or not having, and rather understanding a bit more at the individual level.
Forgive me for a purely ADHD question, but I was at a presentation recently, and the presenter was making the position that the way the ADHD brain works in terms of its etiology, and around dopamine, and that even negative responses produce a positive dopamine response. So therefore, that people with ADHD, even when they feel negatively and sad or poor mental health, actually get a little hit of dopamine. So the
Mm.
position may be that people with ADHD are genetically predisposed to mental health conditions.
And that is in part related to what the data suggests. So if you actually look at studies with genetics, I do some genetic work myself. If you look at the extent to which genetic factors that predicting depression overlap with genetic factors that predict ADHD, there is a 50-50 overlap. So 50% of the genetic factors that have been identified to underlie ADHD also underlie late depression. So this very much fits with this, and it's something that has not been, it's not recognized quite as much. That it's important to consider these genetic factors, but then we also need to design careful studies that can sort of like take this into account and then look within the environment what is also beyond genetic factors that is contributing to these associations, because then these environmental factors can then be very useful for interventions.
If you take the concept of trans diagnosis, and I do like the idea, obviously looking beyond the label or what the one specific box that you can put someone in, and let's not look at it so rigidly. But can that approach be used in perhaps in other areas, like perhaps education?
Yeah, and one thing that was very interesting in this study in TEDS that I presented was that this neurodevelopmental dimension also predicted whether somebody was more likely to have receive to be on the SEND register at age 7 and and also later on. So those that weren't yet identified as SEND at age 7. But were later identified at age 12, they already had elevated neurodevelopmental traits at age 7. So, that might not surprise because obviously these neurodevelopmental traits tend to emerge early. But if we do create this sort of like composite measure, it has some utility to predict who's going to be more likely to require special education support and accommodations. And we are doing some work recently with colleagues at Royal Holloway, a new PhD student at Louise Funnel, to really understand what might be the met and unmet SEND needs, at least in the UK, but also more widely, and how that intersects with neurodivergence and various other areas of functioning.
Thank you very much. I've been hogging it there for a couple of minutes. We've probably time for one more question before we wrap up. Maybe I'll hand over to Valerie at this point.
Sure, thank you, Ken. We had a question in from Lynn, who is actually, I'm not sure if I pronounced that right, and they are watching or listening from Vietnam, so that's great. So Lynn says, what research or study do you suggest to look into the changes of mental health of adults with neurodivergence when they receive support from clinics and or the work environment and family?
And which side do you suggest to look into the changes of?
So I guess seeing if mental health improves after they've received support, is there any research or study behind that?
So I think, studies that are really rigorous and are trying to understand how, standard interventions for mental health conditions work in the neurodivergent individuals are starting to emerge. And, this has historically not been done as well, but there's certainly more studies that are showing that, for example, antidepressants don't tend to work quite as well in people with ADHD, autistic individuals. There is certainly a gap there in needing to develop more tailored interventions for this community. Standard CBT also, when not adapted properly, doesn't seem to be that helpful. And this is something that has also been reported very frequently by our neurodivergent panels. So work in these areas is certainly happening to try and adapt these traditional forms of treatment for mental health conditions, tailor them, adapt them in a way that become more useful to the neurodivergent person. But I think we also need to think a little bit more outside the box and develop intervention from scratch, potentially, if to really target things that might be more unique to the neurodivergent experience.
Makes sense. We also have a comment from Gregory, who says mental health is often the reason that he sees neurodivergent students. Mental health is often the reason that neurodivergent students give when applying for extenuating circumstances in the college where he is. And only sometimes they're saying it's because they're neurodivergent. Is there therefore a case for supporting students in third level education on their mental health as much, if not more, than their neurodivergence and sleep, so it seems?
I think that that's absolutely right. And, that's not, that it's interesting to see that you see that in, requests for accommodations, but that's something that the neurodivergent community very often reports, especially in people that feel very close to their neurodivergent identity, and they maybe wouldn't want their neurodivergent traits, their autistic traits, their ADHD features to be addressed clinically, but they would still want to have attention from clinical professionals, to their mental health struggles that are, at least in their experience, the real culprit of some of their challenges in day-to-day life. And this is something that we're also testing it with data. It's more ongoing work, but we are essentially looking at whether ADHD predicts functioning, or is the co-occurring psychiatric conditions that predict functioning. And you see that it's a bit of both, and then definitely a strong role of psychiatric symptoms beyond anything that could be explained by their ADHD. So certainly something that is really important to address clinically, as much as neurodivergent traits, or instead of neurodivergent traits, considering the individual's person preference.
Yeah, absolutely. That makes sense. We're just right at the 6 o'clock mark now here in Dublin. I know there were a couple more comments there, but I think we might risk running over if we get into anything more. So I'd like to thank Giorgia personally for a really interesting presentation from somebody like a total layperson in this space, and I'm always interested to find out more. So it's very there's a lot there, but it's always broadening my mind. Giorgia, you've very kindly shared your email address.
I think I shared it only with the panelists. Sorry, I will send it again to everyone. So
sorry.
I'm very happy to hear from anyone who is interested in this work. I'm happy to send various papers that I presented, or other resources, or the slides as well.
That's
Thank
very
you
kind
so
of
much
you.
for the very thoughtful discussion. I really enjoyed it.
Yes. Timmy, would you like to wrap up there?
Well, Valerie, I think you've done a fantastic job.
Yes.
So I think on that note, again, thank you, Georgia, and thank you everybody for joining us. This is our final session until the autumn. So do keep an eye on our website and other social media endeavors, and I'm sure we'll have a stellar lineup for you in the autumn. But for now, um, uh, goodbye, arrivederci, and thank you again, Georgia,
Grazie,
and indeed,
Giorgia. Grazie mille.
Thanks very much,
Grazie mille.
yes,
everyone. Ciao.
super.
Bye,
Bye bye.
everybody.
Bye
Thank
bye.
you. Bye-bye.
Bye bye.